Hello and welcome. You're very welcome to the fourth webinar in our webinar series. We're recording this webinar and it will be available on our website later on. This is Edal Murphy here. I'm the Development Officer in the HRB Primary Care Clinical Trials Network Ireland. Some of you have joined before, so I won't go through all the details of how we use it, but I'm conscious there are some new people joining this evening, and not all of you have a mic. So although our presenter will be using, people who have mics can talk. Those of you who haven't, there's an online chat. So I've just sent an online chat message there. It should pop up for you. See if you can find it and just maybe introduce yourselves on it so that you'll know it's working. And that'll allow you to interact with the others on the system. So hopefully you've seen where that popped up. So if you have a camera on your device, you can switch the video on or off. It's your choice, and you can see there's a bit of a mixture there. So the webinar is approved for 1 CPD point. We'll email all those who join a cert tomorrow. So I'll hand you over now to our presenter today, Dr. Joe Gallagher, a GP from Gorey, County Wexford, known to some of you. Joe has a long track record, as well as being a very active GP, of a long track record of involvement in research, and particularly in heart failure. And he's currently the clinical director of the G Health Research Group at UCD. So Joe, thank you very much for delivering our webinar this evening, and I hand over to you now.
Thanks very much, Edel, and hello everyone, and thanks very much for joining us this evening. I hope everyone can hear me okay. If you can't, as Edel said, you can use the chat function and we should be able to see, or if you have any questions during it, feel free just to send a chat message, or if you have a microphone, just feel free to interrupt me at any stage. We've all see heart failure every day in our general practice, and many of you will come across situations or have tips or tricks that you would use yourselves, so feel free to add to it. The structure of this is really 4 cases, looking at stages of heart failure such as diagnosis, the stable heart failure patient, someone requiring palliative care, and then prevention. So it sort of covers all the areas, and as I said, people can sort of dip in and out as they go along. So there's a little poll there that we were trying out to see would it work. It's really, these are just some questions to think about as we go along through it. But I suppose in a GP practice, or a GP with an average of 2,000 patients, they expect maybe to have 40 to 50 patients with heart failure and maybe 5 new cases each year. And that changes depending on the age profile of your practice, and obviously with an older population having more cases. But it's certainly not, heart failure is not the most common chronic condition you'll see in general practice. But it is one of the ones that causes a huge amount of burden for both patients, their families, and for healthcare professionals as well. And it's a bit like the horsemen of the apocalypse, which this picture is now, because it comes as the end result of a number of other conditions, whether that's diabetes, ischemic heart disease, hypertension, and often they have high levels of comorbidity and other healthcare needs and social needs. And this was a study that Liam Glynn had done when he was in Galway, looking at the sort of demographics of people with cardiovascular conditions in general practice. And you can see, even compared to those people who had other cardiovascular conditions, people with heart failure tend to be older, they attend their GP quite often, they have quite a number of comorbid illnesses, on average 4 other illnesses, on a lot of repeat medications, on average 11 repeat medications, and they have high rates of use of things like benzodiazepines and antidepressants, reflecting this very complex mix, which isn't just the heart failure itself, but all its attendant comorbidities and social issues that we see in it. If someone was diagnosed with heart failure and Googled it, they don't get very good headlines. And this was from a paper published a number of years ago, 2001, I think it was, which the title was More Malignant Than Cancer. And often heart failure is compared to many cancers in terms of its mortality. And this was a study carried out in the community by David Hobbs, a GP in the UK, over 10 years, and he followed people with heart failure and age-matched controls. And the top line here shows that the average population is expected gradually deteriorates over time, and after 10 years, 75% of their population, general population, were dead, or 75% were still alive, sorry. Whereas for those with heart failure, it declines much more quickly, and after 5 years, almost half the people were dead. And after 10 years, almost 3/4 of those with heart failure were dead. So it has had a very bad press in terms of of its effect in terms of its morbidity and mortality. So, anyone any thoughts or comments about that, or anything that, you know, do those facts sort of surprise you, or is it your experience as well that this is the type of things that happen? Cool. So, so I'll move on to some of the cases then. So it's a bit like Judge Judy, the cases are real, the people are real, but we've changed the names. And these are all cases from our own practice here, which is, as he does, is in Gorey in Wexford. So this one is really around diagnosis. I think it's a common enough case of what we might see. First lady, elderly lady with history of hypertension and diet-controlled diabetes. She's mild hypertension. She's some ankle edema. She smokes. And she's complaining of being slightly breathless and walking up a slight hill or after 50 yards in the flat. You know, she's on some medications such as amlodipine that might cause the ankle swelling. She has risk factors for both cardiovascular disease and for chronic lung disease. And the question is, how do we investigate this further? You know, diagnostics is really difficult to access in general practice for a lot of these things. You know, some of the things that you could look at are things such as the ECG. So if you have access to ECG, you know, a normal ECG, you can say with around 90% certainty that someone doesn't have heart failure if the ECG is totally normal. Her ECG is, you know, sinus rhythm, but she does have some evidence of left ventricular hypertrophy, which would tie in with her history of hypertension. She has a normal chest X-ray, and that's one of the challenges of chest X-ray, particularly in chronic heart failure. The chest X-ray can be totally normal, and it's probably of more use in something such as heart failure in terms of ensuring that they don't have something else such as lung cancer. Spirometry, if you have availability to it, her spirometry suggests sort of an obstructive pattern. But the problem with this is that, you know, the fluid on the lungs and heart failure itself can cause an obstructive pattern. So it can be very hard to tell if someone has COPD and heart failure, or if this is heart failure causing an obstructive pattern. In general, the sort of the practical approach to it is, you know, you sort of have to decide, well, I think this is more likely COPD. And if someone isn't responding well to those treatments, you should always consider heart failure as being a comorbid cause of it, even if their spirometry is abnormal. It's also important to note that around a third of patients with COPD will have heart failure as well. So they're very common bedfellows in terms of what you see. But probably one of the most useful tests in terms of saying is this heart failure or not are these peptides NT-proBNP or BNP, the natriuretic peptides, because if they're normal, you can say with almost 100% certainty this person does not have heart failure. Whatever is causing their symptoms, it's very, very unlikely to be heart failure. If they're elevated, it does, and obviously the higher they are, the more likely it is that this is heart failure. But it certainly guides you towards, well, we need to look into this a bit further. And the normal levels, and we'll come back to that in a minute, different labs and different guidelines have different levels. The sort of the guideline we use here on the East Coast is around NT-proBNP of less than 250 is normal, or a BNP of less than 100. So you sort of need to know which one has been used in your lab. Although they're both of equal value in terms of heart failure, they have different reference values. So this lady is well above the 250 mark, is 1,288. And with that, then really the next step would be to try and get an echocardiogram to try and clarify, is this heart failure? And one of the reasons you sort of still have to go and get the echo is twofold. One, there's a lot of things that put up your BNP or NT-proBNP. It can go up in even things such as chronic lung disease, inflammation. You know, in atrial fibrillation, it can go quite high. And the second reason is that the echocardiogram guides you as to what the type of heart failure is and then what sort of treatments you might use. So in this lady's echocardiogram, and I've mentioned here sort of the main things that would often be mentioned in the report, they talk about the ejection fraction. So that's really the amount of blood that's pumped out of the heart with each beat. It's normally 50 to 70%. So hers is low, it's 35%. They mentioned that she had mild mitral regurgitation. So mild valvular regurgitation is almost universal. It's sort of a variation of normal. So you can ignore it, even in young people, if they're saying trivial valve regurgitation. That's sort of something that almost everyone has, so you can ignore it. But they did also comment that she had regional wall motion abnormalities. And what that means is that some parts of the heart muscle aren't moving as well as others. And that's very suggestive of ischemia being one of the causes. So those parts of the heart muscle aren't getting a sufficient blood supply, so they don't move as well. So so from this, we can see, yes, this lady certainly has heart failure because her echocardiogram shows features of this reduced ejection fraction, which means the heart isn't pumping as well. Her spirometry is also abnormal, and that could be because she has COPD as well, or it could be because she had built up some fluid. But with time, we can sort of characterize that a bit more. So those are sort of the set of investigations you might use. This is the guideline from the European Society of Cardiology. It talks about assessing the probability, which is looking at, well, risk factors for heart failure. So these are the same as any other cardiovascular risk factors. Symptoms such as orthopnea or PND, any physical signs of heart failure, and any signs of abnormalities on an ECG. And then if you see any of those, then they say, first time, think about doing a BNP or NT-proBNP test. Now, they have very low values here. They talk about an NT-proBNP of less than 125 mean normal, or a BNP of less than 35. They're very low, and I suppose they're really erring on the real side of caution. In general, we tend to use an NT-proBNP of less than 250 and a BNP of less than 100. And so if levels were beneath that, and particularly if you could think of it seems to be another cause there, we tend to say heart failure is unlikely and you don't need to go any further. If it's elevated, then they should get an echocardiogram, and certainly the more markedly elevated is, ideally the quicker they should be seen. But that's obviously an ideal rather than a realistic target at present, unfortunately. So as mentioned, the natriuretic peptides, so these are protective hormones secreted by the heart and vascular system, and they respond to a whole load of things, predominantly volume overload as seen in heart failure and pressure overload, but also ischemia and other forms of inflammation and fibrosis, and they protect the heart and cardiovascular system. So they're although we think of an elevated natriuretic peptide level as being bad, it's actually quite good for the cardiovascular system in terms of protection. I mentioned one of the reasons for doing the echocardiogram is to try and find out what type of heart failure it is. Traditionally, we've always talked about this systolic heart failure, where the heart failure can't pump very well. Like all things, they had to change the name of it, and it's now called heart failure with reduced ejection fraction. This is a type of heart failure for which we have a lot of good data on medications that can be used. This is the heart failure that benefits from ACE inhibitors and beta blockers, and it's the one that was traditionally always seen in the hospitals after a heart attack. But increasingly it's been recognized that there is a major second type of heart failure called heart failure preserved ejection fraction. This now is increasing rapidly and probably makes up 60% of the heart failure we see in general practice. So the heart is a bit like a bicycle pump, I always say. You can pump the blood out, but if you can't draw the blood back in, it's not going to work very well either. So in heart failure preserved ejection fraction, the heart is pumping fine, but in actual fact, it's very stiff. So when it tries to relax, it doesn't relax very well. So there's only a small volume of blood coming in. So therefore, the heart still, although it's pumping out the right amount of, right percentage of the blood, it's not doing very well on drawing the blood in. So you're still developing all the symptoms of heart failure. It can't be differentiated clinically from heart failure reduced ejection fraction. It has all the same symptoms. The natriuretic peptides, the BNP and NT-proBNP will also go up. But the big difference here is that we don't have any good evidence-based treatments for heart failure with preserved ejection fraction. All the studies they've done to date have not found a benefit of medications such as ACE inhibitors or beta blockers in this type of heart failure. And particularly in this older, multimorbid population, it can be a relief sometimes to know, well, we don't need to start all these medications. You may be using these medications in people with heart failure with preserved ejection fraction for other things such as their hypertension or their diabetes or managing the atrial fibrillation, but you certainly don't need to be forcing them into those medications just because they've got this heart failure preserved ejection fraction. By contrast, those people with heart failure with reduced ejection fraction, they do benefit from ACE inhibitors and beta blockers, even if they don't have another reason to be on them. And they also seem to benefit from a high dose as possible. So you find that, particularly in the clinics, they'll be trying to push them onto these medications. And so the echocardiogram is the only thing that can really tell you the difference between these two types of heart failure, and therefore helps guide you on the treatment that might be used. Just to show you some images, this is what an echocardiogram looks like. You can see it's a bit like a fuzzy image, an ultrasound, and you can see here this is the left ventricle here and the left atrium, and the valves are opening and closing. Increasingly, and this is a normal one here, increasingly you'll hear people using cardiac MRI, and that gives very, very detailed images. And you can see here, this is an image here of a cardiac MRI. It's been slowed down but you can see all the structure of the heart. You can reconstruct images. You can look and see things such as muscle damage that may have come from previous infarcts. You can see if there's good blood flow to the heart. You can see if there's any damage to the muscle from viral infections. And I think increasingly the specialist clinics are using this more and more, as it can give them more information with one test. And you can even see here, I'm not sure if it's projecting well, you can see the flow of the blood through the heart and everything. They're really quite amazing images in terms of what they can reveal. So anyone, any questions about that case or any comments? Cool. I'll end this poll here. Excellent. Okay. Well, on to the second case is really a man with stable heart failure. So this man is known heart failure. He's had heart failure due to ischemia, and his ejection fraction is 38%. So if you remember, the normal is 50 to 70%. So he has this heart failure reduced ejection fraction. He's a history of COPD, hypertension, and hypothyroidism, so many of the common comorbidities seen with this. He's had stable symptoms for 2 years. He's no chest pain. His heart rate is 88 beats per minute and regular. Blood pressure is up a little bit. Chest is clear, and he's no ankle edema. And he's on sort of the normal range of medications: aspirin, ramipril, amlodipine, bisoprolol, rosuvastatin, furosemide, altroxin, tiotropium, and salbutamol. So I suppose just try to think through what sort of issues, if he comes in, what sort of stuff can you check through in your mind to sort of try and see, well, what sort of stuff should we be looking at in someone like this? So let's see if this works out. So this is sort of a flow chart of trying to adapt from the guidelines and what they sort of suggest we should look at in patients with heart failure. So I suppose one of the important things is to confirm the diagnosis of heart failure with some sort of imaging. They did a study in the UK looking at patients who've been coded as having heart failure. And I suppose similar to here, there was often difficulty in accessing specialist opinions and specialist tests such as echocardiography. So they went and they did echoes on all these people, and they found that really only around 1/3 to 50% of those people actually had heart failure after they did the echo. And that's not because the GPs were bad at diagnosing it, but heart failure now is a very different beast. It's a very slow onset, gradual condition. It overlaps with so many other things such as COPD, frailty, and it's very hard to differentiate it from these conditions. It's not the pulmonary edema of old, thankfully. And that's because many of these people have very good cardiovascular control by GPs. And so the syndrome of heart failure is very slow onset. So once you've confirmed the diagnosis, really then you should have a cause, because heart failure is a syndrome. It doesn't exist on its own. And it will have a cause, whether it's hypertension or ischemic heart disease or diabetes or an overlap of all three. So obviously you treat the underlying cause. Self-care education, which is the same as for any other cardiovascular disease, is important. And then you can use diuretics, and predominantly loop diuretics, to treat congestion. And that's the real role. They're really a symptom treatment rather than a prognostic treatment. So then once you've done that, you need to know what the ejection fraction is. And in those with a low ejection fraction, and the most recent guidelines, which were published in 2016, call an ejection fraction of less than 40% of diagnosis is heart failure with reduced ejection fraction. And in those people, they suggest that you should aim to have them on an ACE inhibitor or an angiotensin receptor blocker if an ACE inhibitor isn't tolerated, a beta blocker, and a mineralocorticoid receptor antagonist, or what I used to call an aldosterone antagonist, so something such as spironolactone or eplerenone. And the reason for these is that the ACE inhibitor and the spironolactone, they block the aldosterone system, which is upregulated in heart failure and is causing fibrosis and damage to the heart. And the beta blocker blocks the sympathetic nervous system, which is also upregulated in heart failure and is damaging to the heart. So they like to see people on all three of those drugs if they have this low ejection fraction heart failure. Often you'll find that their ejection fraction will recover once they're on these sort of treatments. And in actual fact, after 3 months, you can find that their ejection fraction will go from 30 or 35% up to 40, 50 or 60%. So it can have an effect itself. And they say, well, look, if the person's ejection fraction increases on the good treatments and their symptoms are well controlled, nothing else to be done. If they're after being on these treatments at the best tolerated dose and you find that they're still not getting better, they have a couple of suggestions that they've suggested. One is that you can switch from an ACE inhibitor to this new drug, which we all got missives from the HSE about recently, which is called Entresto or sacubitril valsartan. This is a new drug which focuses on two systems. The valsartan is blocking the angiotensin system, and then sacubitril is a neprilysin inhibitor. Neprilysin breaks down BNP. As we mentioned earlier, BNP is a protective hormone, and the theory behind this was, well, if you increase the BNP, this will help further further protect the heart. And so the drug acts to protect you from the angiotensin receptor system, and then to increase the BNP to protect the heart. And a study published in 2015 suggested that this did have superiority in those people who had persistent low ejection fraction, and is of use in that cohort, which is, to be honest, a relatively small cohort overall, particularly in general practice. One of the issues with a low ejection fraction heart failure is that you're at risk of sudden death. So these people are more risk of arrhythmias, and therefore they talk about devices being inserted, and we all probably have at least one person in our practice who has one of these in. The main devices are an ICD, or an implanted cardioverter defibrillator. This is literally just a defibrillator that sits in your heart, and if you go into ventricular fibrillation, will shock it. And I'll show you sort of a video of that working in a little bit. It doesn't improve symptoms, has no effect on symptoms, so it just prevents sudden death. The other device they talk about is CRT, or cardiac resynchronization therapy, and this is essentially a pacemaker that sits in the heart, and there is a wire in both the right ventricle and the left ventricle. And what this does is, in people who have a left bundle branch block, the left side of the heart, because of the delay in the conduction, is beating slightly after the right side. So you get a sort of a swinging motion if you're to see it on one of those MRIs. It doesn't beat nice and together like that. It sort of swings over and back. And the theory behind this was that by putting a pacing wire into each ventricle, you got them both to beat together again. And therefore, that does help improve symptoms and reduce hospitalizations, and improves prognosis. You can actually put both in together in one device. They're sort of programmable, but again, it's a very small number of people. And then again, another very small small print area is that if a patient is in sinus rhythm and has a high heart rate, you can consider trying to reduce the heart rate further using procorolin. But really, I think people at this level, I think, will be in a specialist service and really need monitoring like that, because they're quite complex to try and manage these things. I suppose if we were to think about this here in John, the last man we had, his diagnosis has been confirmed. We know the cause, which is ischemia, and we know the ejection fraction is 38%. So that's in that heart failure reduced ejection fraction part. We're treating his ischemia with the aspirin and then with the rosuvastatin, so that's under control. We have him on an ACE inhibitor, but his blood pressure gives a little bit more room to increase this up a bit. So one of the things we could do is maybe to increase his ramipril a bit. His heart rate is up a little bit at 88, so we could increase his bisoprolol a little bit as well. And I suppose one of the tricks is, if we were running into problems with his blood pressure, or he had a lower blood pressure to start, we could stop his amlodipine, because although it's good for his blood pressure, it doesn't improve his prognosis with his heart failure. Based on the guidelines, they would also suggest that we would add in this mineralocorticoid receptor antagonist to try and help improve his prognosis. So the spironolactone that's added in isn't as a diuretic, it's more, it helps block the aldosterone that can cause fibrosis in the heart. Now, one of the big challenges with that, and certainly the same for us, is potassium, because all these drugs are putting up their potassium. And I work up here in Gorey, and our bloods go to the lab in Waterford. And I think they start off with a potassium of 3.7 when they leave Gorey, and as they go through Bunclody and on down, it gets increasingly higher. And normally at this time of the evening, we get a call from the lab saying their potassium is elevated. And so it's very difficult to try and implement this sort of regime in general practice. So, again, it's trying to be practical about it. But that would be the ideal situation for someone like John, that we would increase his ramipril, increase his bisoprolol, we could drop the amlodipine and add in either spironolactone or eplerenone to improve his prognosis. Because his symptoms are stable and his ejection fraction is above 38%, he doesn't need any of those devices or other interventions. What if John's ejection fraction was increased? If it was above 40%, to add to the confusion, they added in this mid-range ejection fraction category in the most recent guidelines. But essentially, you can consider that the same as heart failure preserved ejection fraction. Their comment on that, this represents almost 60% of the patients we see in general practice with heart failure, is that no treatment has yet been shown to reduce morbidity or mortality in patients with these syndromes. So they just recommend you treat the underlying comorbidities such as hypertension, diabetes, and atrial fibrillation, as you normally would. And in reality, you will find that most of these patients will be on things such as ACE inhibitors and beta blockers just because you're trying to manage their hypertension or their atrial fibrillation. So they'll end up on these anyway. It's not that they're bad for them, it's just that you don't need to always put them on it. So in that 80-year-old person who is, a low blood pressure and is frail, you don't need to be pushing them onto these drugs. Anyone, any questions on that or any comments?
I'll just say, if you want to unmute your microphones, if you roll your mouse over the bottom of your screen, probably you should see where you can do it. If anyone wants to talk.
Cool. Okay. I suppose just to give you a good news story of what can be achieved. This is a graph from the Heart Failure Clinic in Dunleary, which is our sort of just north of us here. And they looked at, well, what's the prognosis of someone with heart failure who's managed in sort of a disease management program. So they have a new diagnosis clinic there on a Friday where patients with suspected heart failure can be referred for sort of a one-stop shop where they can get their BNP test, get their echo, and see the cardiologist all in the one day. And they looked at following up this population over 5 years. So in the patients who went to that clinic and didn't have heart failure, around 15% died over 5 years. In those who did have heart failure, around 35% died over 5 years. But that is much less than the 50% that was seen in the study done in the UK. So the early institution of these sort of treatments and managing their cardiovascular does have a significant prognostic impact on these patients. And this was a modelling study from the UK. We talk a lot about time to treatment and cancer, but the same thing happens here. They modelled what would happen if you delayed treatment in someone with this heart failure with reduced ejection fraction by 6 months. And essentially they found that over 5 years, they would lose around 6 months of life. So their life expectancy would reduce by 6 months if there was a delay in 6 months when getting them treated. So I suppose and particularly in the average age of a person diagnosed with heart failure is 72. So it's quite a significant amount of time really, based on trying to get them appropriate treatments and just implementing them. So, but I think it is important to recognize that many patients with heart failure, there's still a much more significant mortality and morbidity compared to the general population. And particularly patients with heart failure not only die from heart failure, but the vast majority die with heart failure. So they develop other conditions, and heart failure can become not the cause of the death, but certainly something that can really limit their quality of life. And I was struck by this in the nursing home population as well. It can be very difficult to manage. I suppose in terms of the people who really are at risk of dying in the next 6 months from heart failure, these are sort of things that they sort of watch out for. So people who are ending up in hospital quite a bit, people who have got arrhythmias such as ventricular arrhythmias, if they're needing frequent IV diuretics, if they have chronic poor quality of life, or they'll be starting to lose weight. So a bit like cancer, you get this cardiac cachexia where people lose weight from the pro-inflammatory state that happens in end-stage heart failure. And these are things I think we all sort of intrinsically recognize in patients as they come into the door and become more frail, but certainly then it can be an issue. And the other problem is that, and this was a study that was done in the Netherlands, is that around 75% of people with heart failure die from another condition, such as cancer, but their heart failure can have a really big impact in terms of their managing their palliative care needs and what happens with it. And this was a man in our practice who was 76, had a diagnosis of prostate cancer with spine metastases, and he was bedbound, and he really didn't want to go back to hospital again. He was under the care of the palliative care team. He was, he had made his decision that, he wanted to be at home and kept comfortable. He had a history of heart failure with this quite low ejection fraction. So again, the normal is 50 to 70%. His was 20%. And he had a pacemaker and a ICD inserted 7 years ago. And one of the things with these is that often the ICD never goes off and everyone forgets about it, and then they get something like cancer and everyone's focused on that. And then we reach this stage where the person is reaching the end stage of their disease, and all of a sudden we have to think about what's happened with the ICD. So he had quite marked short of breath, even getting dressed. He had quite a dry cough. He was literally almost sitting up in the bed when he was trying to sleep and waking at night short of breath. His pain was under good control, but now his major problem wasn't the pain, it was his heart failure and these sort of symptoms. And when you looked at his thing, he was on MST and Severdol, he was on diphene PR for his spinal metastases, on cyclizine, and still on all these, very good medications for when we were actively trying to manage his heart failure. I suppose one of the challenges was, well, what were the, how are we going to manage this, and what were the main issues? Now we're sort of approaching what was felt to be the terminal phase of his illness. So I suppose one of the things looking through the list is that the diphene is quite likely exacerbating his heart failure, because NSAIDs, as you know, can obviously lead to fluid retention and make the heart failure worse. So you may well decide to stop the diphene and try increasing some of the MST or Severdol if needed. He appears to have quite a marked decompensation in his heart failure, and he's only on Buronex, he's on 1 milligram twice a day. So you could try increasing that up quite a bit. You could go to, instead of 1 milligram twice a day, go to 2 milligrams twice a day, or 2 milligrams more than 1 milligram at night. But one of the problems is it does sound as if he's getting this paroxysmal nocturnal dyspnea. And when you're seeing that, often that means that he's right heart failure, the gut will be quite congested, and it can be very hard to get medication absorbed. So you may find that you increase the diuretic, but it's still not improving his symptoms. There's a couple of tips you can use for that. So let's see, can I get this to move forward? So one of the things that can happen is that the loop diuretic, as you know, it blocks this and it's a bit late in the evening to be showing these sort of pictures of renal physiology, but the loop diuretic blocks the ascending loop of Henle. And so one of the things the body does when you're on chronic loop diuretics is that it starts to reabsorb more of the salt here in the distal convoluted tubule. So you get this diuretic resistance where you can increase up the loop diuretic as much as you want, but the distal convoluted tubule will keep absorbing more salt, so therefore the effect is lost. One of the tricks you could use with someone like that man who you're really trying to avoid sending to hospital, but if the loop diuretic wasn't working, is you can give a thiazide diuretic just before, an hour before you give the loop diuretic. The thiazide blocks this distal convoluted tubule, and then the loop diuretic will work an awful lot better. It can be quite a dramatic effect. Someone can lose 2 to 3 kilos in weight over a day. So it's not something that you need to do sort of every day for a week. Often a day or two will have quite a dramatic effect on this. And you actually sort of have to warn people not to take it every day, or they'll end up like a raisin all dried out. That's one thing that you could use in someone like that, where you're trying to avoid hospital, but they're very distressed by fluid overload, and an increase in loop diuretic isn't working. In the palliative care setting as well, you can give furosemide intravenously, obviously. You can also give it intramuscularly, and you can also give it in a syringe driver if it's a problem. Although it's not that often you need to give it in a syringe driver. Often that can be managed with other ways, but it is possible to give it if fluid overload is an ongoing problem. The other thing that can be very useful from a comfort point of view is a nitrate patch, because it causes the pulmonary veins to distend and the fluid doesn't collect as much in the lungs, and therefore that symptom of paroxysmal nocturnal dyspnea can really help, be decreased. So in John, that man that we had, we gave him a nitrate patch to put on at night. We use this technique of giving him a thiazide diuretic. They traditionally use metolazone, but I use indapamide because it's what the chemist had. He lost 10 kilos over 3 days. His symptoms improved quite markedly. We stopped the diphene as well. We did have to increase the MST, but in actual fact, he settled down quite well and became much more comfortable from a respiratory and sort of dyspnea point of view. And we're able to manage his symptoms quite well at home. I mentioned the ICD, and that's one of the issues about turning that off, because if it can shock people at the end of life. Obviously, as you approach death, it's much more likely you'll go into sort of arrhythmias, and that's a natural part of the dying process. So it is important to try and remember to switch it off. It's really the responsibility of the cardiology or oncology team who are looking after them, but sometimes that can get lost in the mix. For John, we were very lucky. One of the technicians came out to turn it off for us, because it's just done with a computer. It can be done remotely in some instances, and I think that can be useful, but it's just something to see. But they are real life-saving devices, and this is just a short video, and I hope you'll be able to see it, of a football player in the Netherlands who has an implanted cardiovascular defibrillator in place. And you'll see him here. So hopefully this will play now. So I'm just going to go back and forward again. So this man here, if you just look at this guy here. So this is him collapsing, and after you can see he'd gone into ventricular fibrillation. If you watch closely, you'll see him give a little jerk. That's the shock being delivered. And that's him sitting up. So in these sort of life-saving situations, it can be quite dramatic and really do save lives, but in the terminal phase of life care, they can be quite problematic, because you can imagine that sort of a shock could be quite distressing for family members as well. Yeah. So in terms of palliative care or decompensation, you can increase the dose of diuretic, the use of nitrate patches, obviously using things like oral morphine or lorazepam to reduce anxiety. Home oxygen, I think, has a limited role. It's often the flow of oxygen helps eases the sensation of dyspnea rather than having actually improving the oxygen levels. And then you can also use diuretics either subcutaneously or intramuscularly. So that can be a useful tool. Stopping medications obviously is important to think of as well. And so we're all I think, well accustomed to in terms of palliative care settings. Diuretics are the main one to improve symptoms. These other medications can also help improve symptoms to variable degrees. In reality, diuretics, nitrates, and morphine are the best symptom improvement, whereas ACE inhibitors, beta blockers, and digoxin, it's a much more gradual, and often with low blood pressure, may be better to stop them. They talk about advice use of NSAIDs if possible. Now, I do use them in people with heart failure who have a lot of pain, but if it's causing problems in terms of fluid overload. They talk about cyclisine might exacerbate heart failure. There's some studies that suggest that it may do. You can use nosin, and again, it's something that it's still used routinely, but if heart failure is becoming problematic, something to consider. And then domperidone at high doses has been associated with causing arrhythmias. So someone like John, who had a lot of devices in, it might be available to avoid it. And don't forget to consider deactivation of ICDs in case everyone else has. So some good points here. Actually, I see that's been sent on the message board here. Colette, thanks very much. Does heart failure preserved ejection fraction deteriorate to heart failure with reduced ejection fraction? It's a really good question. It can sometimes. So you will find that if symptoms are worsening or things aren't improving, it is worth getting a repeat echo in someone who initially presented with heart failure with preserved ejection fraction and things are getting worse. So something like ischemia can worsen, and you can find a small number of people, maybe 2 to 3% per year, go from preserved ejection fraction heart failure to ejection fraction, reduced ejection fraction heart failure. Claire also made the point that wheeze can be a presenting feature and it's a confusing diagnosis, and I totally agree that there's so many times that I'm treating someone for COPD and after 6 months I realize no, it's actually heart failure, and it's really difficult to separate out the two, and you really also have to have a high index of suspicion that in someone who's got these risk factors, who isn't responding to other treatments or not behaving as they should, that this is where the BNP test can be useful in terms of you can check it, and if that's elevated, maybe we're considering an echo. I had also suggested that you could catheterize a patient with prostate cancer. I think that's really important as well. If you're increasing diuretics, in someone's bedbound, having a catheter in can be really useful, because as much as relieving the dyspnea, you certainly don't want them to be feeling that they're constantly passing urine. And particularly with that thiazide diuretic combined with the loop, it works so effectively that you can actually find that they're passing large amounts of urine. Nadia had also made a very good point about the combined loop and thiazide diuretics and electrolytes, and you really have to be careful because it can have quite a dramatic effect, and they can lose a lot of potassium and sodium with it. And so certainly if you're using someone who you're actively managing, you should check their electrolytes a day or two later to be sure that it hasn't dropped too much, particularly if they've lost a lot of weight. The weight is a really good sign. If they've lost 2 or 3 kilos over 2 days, well, then you may need to consider if they lost a lot of potassium as well. That may not be as much of an issue in someone who's in palliative care in the terminal stages, and you're just really trying to achieve symptom control. But that's why it's also important not to use it on an ongoing basis. So it's not something you use every day for a week. I'd use it for a day or two and then just see how they've done, and often that'll be enough to settle things down. Great. So the last case is relatively short, and it's really just to highlight something that is very involved with here in on the East Coast, and indeed some of you may have been involved with. So this is a man, his history of hypertension and diabetes. He comes in and he's known to have some ankle swelling, and so a bit like the First Lady. He's quite well controlled, LDL, his HbA1c is good. He's not really that much symptoms, but you do an NT-proBNP test and it's elevated 225, so it's up a little bit. But when he has an echocardiogram, it's reported as normal. And so the question here is, well, the fact that his NT-proBNP is elevated, is that an indicator of anything else, or does he have any extra risk? And so this is a graph that shows that this was in people with stable coronary artery disease, and they show that the higher your NT-proBNP or BNP, it doesn't matter which one you're using, the higher risk of mortality. So it is associated with mortality, and that's probably because it does respond to ischemia, it responds to pressure overload, it responds to fibrosis in the heart. So it's sort of telling you, well, that's up to that person's body is responding to some perceived threat. So it's very useful in terms of risk stratification. And there's a study here done on the East Coast called the STOP-HF study, and it involved 39 practices all along the East Coast of Ireland with St. Vincent's Hospital as well, and involved a lot of patients who had cardiovascular risk factors such as hypertension, diabetes, a history of angina or stroke. And they essentially, what happened in that study was that they checked the BNP level in everyone who was involved in the study. In half of the patients, those who had a BNP above 50, they underwent sort of more intensive management of the risk factors. And the other half, no one knew what the BNP was till the end of the study. And they found that by taking that approach of treating people based on their BNP, in actual fact, they had a significant reduction in the incidence of heart failure. So it reduced by 41% overall in the groups. It went from 3.8% down to 2%. But the main effect wasn't just on heart failure, it was actually on all these other things, such as stroke, myocardial infarction, and arrhythmia. And it had quite a dramatic reduction in all of these. And that makes sense because NT-proBNP is responding to a whole range of things and risk factors. And therefore, if you treat people, the cardiovascular risk of people aggressively based on having a higher BNP or NT-proBNP, well, then you're going to reduce all their other cardiovascular events as well. And so this study then was replicated in Austria in a group called the Pontiac study. And there's not that many things we give to USA apart from a bowl of shamrock every Paddy's Day. But in the guidelines this year, the American College of Cardiology have now included this approach as being a way of helping to reduce or of preventing heart failure. And so it's now part of the American College of Cardiology guidelines. The Canadians have also included in their guidelines that in those people who have a elevated natriuretic peptide but do not have heart failure, that really we should try and intensively treat their cardiovascular risk to reduce the onset of heart failure and also of other cardiovascular conditions. We've been doing some work with the Midlands Diabetes Cohort, which many will know is a group of general practices who are involved in managing diabetes. In that group, we took a similar approach, but in this case, the cardiologists weren't really involved. The GPs had access to echocardiography and then treated patients themselves intensively. And the interesting thing about this is the left-hand column here shows the group of patients in the Midlands who needed an echocardiogram because they had an elevated natriuretic peptide, and shows the sort of cardiovascular risks, such as their HbA1c, their lipids, and their blood pressure, compared to these two big diabetes studies. These were intensive diabetes studies published, I think, in the New England Journal of Medicine. So very high-level things. And you can see the GPs in the Midlands are managing their patients as good as, if not better than those in the intensive arms of randomized controlled trials in the New England Journal of Medicine. But it's a fantastic endorsement of the approach that's happening there. The only thing that picked out this group of patients was that they had a higher NT-proBNP, an average of 417. So all these cardiovascular risks were really well controlled, but this still sort of peaked up at us. And so when you looked at this, we went and did an echo, and there's a lot of variables here, but essentially a third of that group actually had evidence of sort of impaired heart function overall. So in this world where the diabetes control is much better, the lipids are better, the blood sugar control is better, NT-proBNP is still identifying this group of people who do benefit from more intensive control, and we can see this even in general practice itself. So if anyone has any comments, feel free. Actually, I see that the chat room seems to work well. So feel free to send any other comments. But I suppose just to summarize, you can use natural peptides to rule out heart failure. If they're normal, someone doesn't have heart failure. If they're elevated, they could well have heart failure. But an echocardiogram or some other imaging, is still needed to confirm that they have heart failure, and also to help guide treatment. So do they have this reduced ejection fraction or preserved ejection fraction? The loop diuretics help symptoms, and that's very important, but don't improve prognosis as far as we're aware. For those people who have a low ejection fraction, the aim is to get them onto 3 main drugs: an ACE inhibitor, a beta blocker, and a mineralocorticoid receptor antagonist. That is really for improving prognosis. For those with preserved ejection fractions, the ejection fraction is normal. Well, then it's really, you can use whatever you want to get good cardiovascular management. So you don't have to aim to get all those drugs on. You don't have to aim for all these really high levels of ACE inhibitors and beta blockers. Just manage the patient, ensure their blood pressure is controlled. Whatever, if they have diabetes, is well controlled. But you don't need to proactively use all these drugs. You can still use your loop diuretic to control symptoms. And this, again, this preserved ejection fraction is probably the predominant cause of heart failure that we see in general practice. And then the other thing is that if you do have somebody thought of heart failure, and they have you do a natriuretic peptide and it's elevated, but then you find that their echo or their test is normal, well, then they still have higher levels of cardiovascular risk. And so you should approach that sort of aggressively to try and reduce their risk of heart failure, but also the risk of other cardiovascular conditions. So I hope that was of some use. And if anyone has any questions or comments or thoughts, please feel free to either send them by chat or to shout out.
Yeah, thanks a million, Joe. I've unmuted, so hopefully if people have mics, they might be able to throw in a few comments. Brilliant presentation, Joe. As a non-clinician, I suppose the complexity of the patients just strikes me so much listening to you, and how challenging it is for GPs to handle them. And great to see the research impacting the guidelines, which is obviously, as researchers, what we'd like to see happening. So really interesting.
Yeah, I think you're right. It's not just the heart failure; it's everything else that goes with it, and often they're frail and elderly. And it's the guidelines are great in theory, but often it's very much cookbook medicine. You have to adjust it to the individual person, and often you're aiming for quality of life as opposed to sort of a prognostic benefit.
Yeah, so varying it depending on the stage of a person's lives.
It's absolutely.
Yeah. Excellent comments coming in. People can't find the mics. I'm very happy. Great presentation, Joe. Really good. It'll be up on the website, and those who came in late can tune into it. And we'll also share it with other people in the network, because I know there's a number of people the time didn't suit them. Yeah. And I think the quality of the presentation is absolutely super.
Thanks very much, Dale.
Unless anybody else has anything to add, we'll just wrap it up there. And thanks again, Joe. Really super.
Excellent. Thanks very much, everyone. Have a good evening.
Bye-bye.
Bye.